Let's talk about restless leg syndrome, or RLS. It's so often brushed off as just having the fidgets, but it is a very real neurological disorder. And what's fascinating is that recently, the entire medical playbook on how to treat it has been completely rewritten.
To really get what RLS is all about, you have to start with the sensation itself. And it's notoriously tough to put into words, which is why you see people using all these different descriptions. It's not a simple cramp, it's not a muscle ache, it's this bizarre, urgent signal coming from deep within the nervous system.
Honestly, this is probably the best analogy I've ever heard for it. Just think about that feeling when a yawn is coming on. It's not painful, right? But it is absolutely irresistible. You have to do it. Well, RLS is that exact same overwhelming command from your brain, but instead of telling your mouth to open, it's screaming at your legs that they must move right now.
Okay, so how do doctors actually separate this very specific feeling from all the other things that can make our legs uncomfortable? Well, it all comes down to a really specific set of rules. The thing is, there's no single blood test or brain scan for RLS. The diagnosis is clinical, which basically means a doctor confirms you check all 5 of these boxes. And the pattern here is everything. The urge pops up when you're trying to relax, it gets better if you get up and walk around, and it has this daily rhythm where it's always worse at night.
And that 5th point is so important. This is where doctors really have to put on their detective hats to rule out what they call mimics. These are other conditions like arthritis or nerve pain. Sure, they can cause discomfort, but they don't have that classic, undeniable, deep-seated urge to move that only gets better when you start pacing around the room.
So what in the world is going on inside the brain to create such a specific and kind of bizarre urge? Well, the clues start deep inside our own DNA. Yeah, for the majority of people with RLS, the story actually begins with their family tree. More than 60% of cases are considered familial, which is just a way of saying it runs in the family. And that really strong genetic link was a huge clue for researchers, telling them exactly where to start looking.
And all that genetic detective work is really zeroed in on 2 prime suspects. First, the way the brain handles iron, and second, a critical neurotransmitter called dopamine, which, as you might know, helps regulate movement.
Now, this is a really crucial point. We're not talking about the iron that's floating around in your bloodstream. You could have a totally normal blood test for iron, but your brain and central nervous system could still be starving for it. And this brain iron deficiency is a huge deal because your brain cells need that iron to manage dopamine correctly. Okay, so this dopamine connection, well, it led to what seemed like a miracle cure for a while. But that early success story had a massive, and I mean massive, unexpected twist.
For a long time, a class of drugs called dopamine agonists were the go-to prescription for RLS. And you know what? In the short term, they worked incredibly well. They give the brain's dopamine receptors a direct jolt, and for so many people, the relief was almost instant. It was life-changing. It really seemed like the problem was solved.
But then this question started popping up, a question that would change everything. As patients were on these drugs for years, doctors started to see this really disturbing trend. The very cures seemed to be making the disease worse.
They even gave this phenomenon a name, augmentation, and it's a truly devastating side effect. What happens is, over time, the RLS symptoms basically fight back, and they fight back harder. They start showing up earlier, maybe in the afternoon instead of just at night. They can spread from the legs to the arms, and the urge to move becomes even more intense than it was before you even started the medication. It's like the brain's dopamine receptors get worn out from all the artificial stimulation, and they become less sensitive.
And this quote from Dr. John Winkelman, who helped write the new treatment guidelines, just captures the whole problem perfectly. Discovering augmentation was a bombshell. It forced the entire medical community to go back to the drawing board and completely rethink how to treat this condition.
So that brings us to today, to the modern approach, which is based on brand new 2024 guidelines from the American Academy of Sleep Medicine. So here's the new rulebook. Before a doctor even thinks about writing a prescription for the RLS symptoms themselves, the very first step, step 1 in the algorithm, is to check the patient's iron stores, specifically a blood test for something called serum ferritin.
And this chart shows you exactly why that iron test is so critical. See, for most people, ferritin level over 20 is considered perfectly fine. But for someone with RLS, the brain just needs more iron to work with. The new guidelines say the goal should be to get that ferritin level above 75, and doctors will often use iron supplements to get it there.
So here it is, the big switch up. As you can see, dopamine agonists have basically been benched. The new starting players, the new first-line therapy, are a totally different class of meds called alpha-2 delta ligands. Drugs like gabapentin. They work by calming down overactive nerve signals. And look, the guidelines now explicitly suggest against starting with dopamine drugs, simply because that risk of making things worse down the road, that risk of augmentation is just too high.
So, what does all this new information mean for actually managing RLS day to day? Well, it's about a lot more than just what's in your prescription bottle.
Yeah, a really smart management plan also means being a bit of a detective about what makes your own RLS flare up. We're talking about the usual suspects like caffeine and alcohol, for sure, but also some very common medications, like the sedating antihistamines you find in a lot of over-the-counter sleep aids, and even some types of antidepressants. And on top of all that, things like untreated sleep apnea or just not getting enough sleep can absolutely pour fuel on the fire.
It's also really important to know that RLS hits some groups way harder than others. It can affect up to a quarter of women in their third trimester of pregnancy. And look at this, over half of patients with end-stage kidney disease. In situations like these, fixing any iron issues and using non-drug therapies is absolutely the preferred way to go first.
So, let's just boil this all down. The big takeaway is that there is a clear, modern, evidence-based roadmap for managing RLS. It all starts with that iron test. It means taking a hard look at lifestyle triggers. And it means prioritizing safer, long-term treatments that won't backfire and make the disease worse.
You know, the thinking on how to treat RLS has just gone through this massive evolution. But with so many people in the US still on those older dopamine drugs, it leaves us with this final, really important question. Being informed about these new rules of relief, well, that's the most powerful first step anyone can take.